Welcome, and thank you for joining this IFA virtual meeting as part of the series entitled Improving Adult Influenza Vaccination in Canada, Learning from International Good Practices. My name is Andra Stanku, Project Officer with the IFA, and we'll briefly review housekeeping. This meeting begins with expert panel presentations, followed by a moderated discussion. Please use the chat function to indicate you have a question or comment, and we will call upon you to pose your question during the moderated discussion. If you have resources to share, please post them in the chat as well. This meeting is recorded and screenshots may be taken and shared on IFA social media. The video recording and resources will be shared on the IFA's Vaccines for Life knowledge sharing platform. It is now my pleasure to pass the floor to Dr. Jane Barrett, Secretary General of the IFA.
Thank you very much, Andra, and welcome to everybody to this important meeting. The International Federation on Aging, for those that don't know, has its headquarters in Toronto, Canada, and we've been in existence for over 45 years. We're closely aligned and have formal working relationships with the World Health Organization and the United Nations, and particularly the Economic and Social Council. The IFA's agenda is very clear. It's about healthy aging, and we have a vision of a world of healthy older people whose rights are both protected and respected. And just recently, the WHO has endorsed, with member states including Canada, has endorsed the Decade of Healthy Aging. That resolution is now sitting with the United Nations, and we very much hope that later this year or going into next year, it will be launched as the United Nations Decade of Healthy Aging. When we're thinking about healthy aging, there are 4 action areas: one about ageism, long-term care, primary integrated care, and age-friendly cities and communities. And when I think about those 4 action areas, I think about what's happening in the world today and how brutally exposed the lives of those most vulnerable have been with the coronavirus pandemic. In ordinary times, and I'm not sure what ordinary is anymore, but in ordinary times, we would have met together to talk about the importance of adult vaccination. And one of the areas that I'm particularly interested in is why Canada doesn't have a harmonised program. As most of you have picked up, I'm not born Canadian. I love Canada. I've been here for nearly 18 years, but I'm an Australian by birth. And so when I come to Canada and live here for so long, I see the inequities that exist across this great nation in terms of access to some of the most important public health interventions of our time, and that is vaccination. And when I asked the question, why, quite often the response was, well, it's because the jurisdictional responsibilities lie with provinces, that's why. And I ask myself, why? Because, when a person, older person living in Ontario has different access to certain vaccines that contribute to their health and well-being compared with someone who may live in BC or Alberta or Manitoba, one has to ask the question why. And so that prompted the IFA to consider, how we could bring experts, but also interested people around this very topic. And if we look at the literature, this is not a new idea. This has been on your agenda for a decade or more. And so we bring it to the table across 3 webinars. This, what we call a town hall, another town hall in a couple of weeks where we get speakers internationally talking about their programs, and then a closed meeting later in the year. And we do this because we earnestly want to try and understand how to combat inequity when it comes to adult vaccination. So today we're going to hear from 2 people who are eminent in their field and probably well known to you. You know, Lucy, I've known for several years, and Lucy is formidable in her passion and advocacy in immunisation. Lucy Marisa Bucci is the Senior Manager for Immunise Canada, and she'll be talking with us about provincial programs and policies concerning adult influenza vaccination. And following Lucy, we welcome Mr. Jeff Meltretter, Vice President of Pharmacy and Business Development, the Neighbourhood Pharmacy Association of Canada, because one of the key barriers to older people being vaccinated is the vaccination pathway, the gateway. So we need to understand how to make it easy for older people and those most vulnerable to be part of and to gain access to the most important vaccinations, which improve their health and well-being. Before I hand the floor over to Lucy, I want to acknowledge the leadership and hard work of Ondra Stanku. Ondra is the project lead for this important series of webinars and works tirelessly, you know, in this field. And also Megan Acton, Program Manager at IFA in vaccination. And I also want to acknowledge the support from Securus in unrestricted educational grant and welcome Kim and her colleagues to this meeting today. So Lucy, I hand the floor to you. Thank you very much.
Thank you, Jane, for the very warm welcome. And you're quite right about our policies and programs in Canada. But before I begin, I just want to say thank you again, Jane, for letting me kick off for the second time in a row this month, one of your great webinar series in town halls. I can't be more happy to be discussing the important issue of adult influenza immunization in Canada with you and your colleagues. And also I want to extend a thank you to your team at IFA. They're just wonderful. Next slide, please. So my objective for the next 13 minutes or so is to really give you enough high-level overview information about influenza immunization policies and programs in Canada so that we can have a fruitful discussion about what is needed to improve our programs here. And I'd like to start with, if you can go to the next slide, please, talking about who are the key actors, the key players in this country with regards to immunization policy and program development. As you well know, responsibility for healthcare in Canada, including immunization, is shared by the federal, provincial, and territorial, or FPTs, as we call them in our field. And each jurisdiction has a distinct mandate and a unique context. However, their activities are not conducted in silos. They are complementary and collaborative. Collaboration is a key component of immunization policy and program development in Canada. And one of the big activities, or the several activities where we could see this data sharing, knowledge, expertise, and sharing of best practices is in disease surveillance and adverse event reporting following immunization. So very quickly, the key federal players are Health Canada, the Public Health Agency of Canada, which is the federal agency responsible for immunization. They help provide leadership, advice, support for timely vaccine recommendations and sustainable immunization programs. The agency is supported by 2 scientific advisory committees who provide expert guidance on all areas in immunization. That committee is NACI, which provides evidence-based recommendations regarding the use of vaccines authorized for use in Canada and advises on the need for national vaccination strategy and makes recommendation for vaccine development research as well. The second committee that advises the Public Health Agency of Canada is CATMAP, or the Committee to Advise on Tropical Medicine on Travel. Now, CATMAP makes evidence-based recommendations similarly to NACI, but they do so relating to tropical infectious diseases and health risks associated with international travel. Occasionally, the two work together to provide guidance when necessary. At the provincial level, governments are responsible for the administration and delivery of healthcare services, including immunization-related programs. They provide immunization policies, and schedules are developed by PT governments or their expert immunization advisory committees. And a good example of that is the SIC in Quebec, the Comité d'Immunisation du Québec, and Ontario has a similar equivalent. And their advice is based on jurisdiction-specific needs, immunization recommended such as NACI, program resource availability and constraints, and identified priorities. Another FPT key stakeholder or actor in immunization policy in Canada is the Pan-Canadian Public Health Network, which was established by Canada's FPT Ministers of Health in 2005 as a key intergovernmental mechanism to strengthen and enhance Canada's public health capacity, enable FPT governments to enhance day-to-day business of public health, and anticipate, prepare for, and respond to public health events and threats. And last but not least is the Canadian Immunization Committee, which is also an FPT government representative who review and provide recommendations on immunization program planning, which are provided to FPT Deputy Ministers of Health through the PHN. And as well as the Council of Chief Medical Officers of Health, which round up the key stakeholders in Canada. Next slide, please. Now, with regards to influenza immunization policy and recommendations at the federal level, it's virtually impossible to talk about seasonal influenza recommendations without looking at the overarching scheme or policy framework that really sets our agenda for immunization influenza in Canada. The National Immunization Strategy was initially adopted in 2003 and reframed in 2016, but has been a platform for collaboration between FPT stakeholders and has facilitated the development of consistent and equitable approaches to immunization planning, vaccine purchasing, program delivery, and education. It also sets vaccination coverage goals. And since our topic of discussion is regarding immunization for influenza in older adults in Canada, the NIS sets an achievement goal of 80% vaccination coverage amongst this population. It also sets to achieve 80% vaccination coverage among adults aged 18 to 64 with chronic medical conditions. So what does that and how does that impact what we do in terms of policy and program or recommendation development in Canada? As mentioned, NACI is the body that sets, that uses evidence-based to create informed recommendations for the PTs. The season for 2020-2021 looks as the following. NACI has published a Canadian Immunization Guide chapter on influenza and statement on seasonal influenza vaccine for this season. In the past, NACI would provide general recommendations, but more recently, they have expanded their scope and mandate to include two types of recommendations: individual level decision-making recommendations and public health program level recommendations. In this season's recommendation, NACI recommends that the influenza vaccine should be offered annually to anyone 6 months of age and older who does not have contraindications to vaccines. The second recommendation is a public health program level recommendation, and NACI makes a similar recommendation in that influenza vaccine should be offered as a priority to groups for whom influenza vaccination is particularly recommended. Within that group is adults 65 of age and older, as well as adults and children with the following chronic conditions. And those conditions is quite a long list. And so the reference below to the recommendation statement will provide you with that list. Next slide, please. Also within NACI's recommendation are 4 types of inactivated influenza vaccines that are authorized for use by Health Canada for adults 65 and years of age and older. Those vaccines are the trivalent inactivated influenza vaccine, standard dose, the same in adjuvanted, high dose, and the quadrivalent inactivated influenza vaccine. Within NACI's recommendation, they say that any of the available influenza vaccines should be used at the individual decision-making level. There is good evidence that the high dose provides better protection compared to the standard dose, but NACI does not make comparative individual level recommendations on available vaccines for this age group in this particular statement. At a programmatic level, NACI recommends that any of the available influenza vaccines should be used and states that insufficient evidence on the incremental value of influenza vaccines to make a comparative program level recommendations are available. And the reason why it has made that statement, I believe, is because NACI now looks at economic, which is more programmatic level recommendations, as well as ethical considerations for their program, for their recommendations. Next slide, please. With regards to adults with chronic health conditions, NACI recommends that any age-appropriate inactivated influenza vaccine should be offered, including to people with immune-compromising conditions. For adults 18 to 59 years of age, there are 3 types of inactivated influenza vaccines that are authorized for this age group. Again, the trivalent standard dose, quadrivalent standard dose, and the live attenuated influenza vaccine quadrivalent. It also recommends that any of the available influenza vaccines can be used without contraindication. In adults 60 to 64, any of the inactivated vaccines should be used in people without contraindication. The standard schedule is 1 dose of influenza vaccine each year. Now, in addition to the seasonal recommendations for influenza immunization, I have added NACI's supplemental statement on mammalian cell culture-based influenza vaccines. And I believe this should be an important reference because it is supplemental, and not only is that supplemental, but it's available. That vaccine is currently, to my knowledge, available in 2 provinces. Next slide, please. Additional guidance by NACI because of the SARS-CoV-2 pandemic. Now, NACI has realized that there is additional guidance required because of the pandemic, and they have published 4, or about to publish 4. I have 4 in my list here. So the first is the guidance for influenza vaccine delivery in the presence of COVID-19. I won't go through all of the major statements, the points in the statements, so I will provide an overview. But in essence, the statement looks at alternative models of influenza vaccine delivery, which is necessary in a pandemic setting, such as holding multiple smaller public health immunization clinics for influenza, opportunistic immunization of patients in primary care, administering vaccines outdoors, mobile clinics, etc. It also recommends screening and physical distancing as much as possible as a measure for infection prevention and control, as well as PPE considerations. And I have included the reference for your review. Guidance on the use of influenza vaccine in the presence of COVID-19 is an additional statement that NACI recently published to reduce the risk of severe illness that could potentially arise from co-infection with SARS-CoV-2. NACI recommends that individuals who fall in the following groups are also particularly recommended to receive the influenza vaccine this fall. People at high risk of severe COVID-related illness include adults 65 years and older, individuals with chronic health conditions. And of interest, for those of you who have wondered, an interesting publication or study was circulated for quite some time with regards to the potential interference between influenza vaccine and COVID-19 disease. And in this particular statement, NACI has found that there is no evidence to support that influenza vaccine increase the risk of SARS-CoV-2. Next slide, please. An additional guidance are the recommendation on the duration of post-vaccination observation period. In this particular statement, NACI recommends that the current post-vaccination observation period should be maintained for influenza vaccination settings that can adhere to appropriate public health and infection prevention control measures for COVID and to reduce transmission for COVID, and particularly physical distancing. However, the committee also recommends that a shorter post-vaccination observation period of 5 to 15 minutes can be done, however, under specific conditions. And those conditions are listed in the recommendations. It is not published yet. There is an advanced copy circulating, so I'd be happy to share that. It is not confidential. And lastly, more generally, earlier on this year, probably at the peak of the pandemic, NACI published the interim guidance on the continuity of immunization programs. So why is this relevant to influenza? At that time, NACI had already begun to recognize that adults and older adults should be preferable to immunization when it comes to combined with other medical visits. So offering multiple vaccines at the same time within the same visit, and that is the same recommendation that is in their interim guidance for flu vaccines during COVID. Next slide, please. Now, I mentioned at the outset that NACI recommendations, as well as other recommendations at the federal level, trickle down to the provincial. Not necessarily trickle, I shouldn't say that. They are collaborative. So PTs are aware of what is happening. They're aware of the evidence, and they often publish their own directives for seasonal influenza program planning and implementation. And as mentioned earlier, they take into consideration NACI recommendations. And these are adopted at the local level. Now, some have expert committees, as mentioned earlier. Some have advisory bodies, such as the SIC is a good example, and I've copied and pasted a nice little example of what their recommendations look like. All of that gets funneled into program planning and implementation at the local level. Also, most PTs that I've seen have also published additional guidance on the delivery of influenza vaccines in the context of the COVID pandemic. I won't go into those guidances because they're quite extensive and very impactful on programs, but in the sense of implementation rather than the planning stage. Next, please. So what does influenza immunization look like, or the programs look like with regards to this upcoming season? Since we're addressing adult immunization for influenza in this particular town hall, I've highlighted in the red box the groups, the target groups who are to receive, who may receive and who may not receive, depending on the jurisdiction, a free or publicly funded influenza vaccine. All jurisdictions, with the exception of BC and Quebec, have universal influenza programs. As you can see, persons 18 years and older and persons 16 years and older in BC are not eligible for an influenza vaccine, but I'm sure they could if they could access one. In Quebec, it's a similar policy. However, if you look at footnote number 6, Quebec has provided a little bit of explanation, and their influenza vaccine is no longer recommended for healthy adults 60 to 74 or healthy children 6 to 23 months. However, if you would like to get the vaccine, you can do so free of charge. So it's upon request. Next slide, please. Now, this is an extension of that table, which is posted on the Public Health Agency of Canada's website. I have sourced it at the bottom for your reference. In this subsequent or secondary part, we are looking at target groups with regards to publicly funded influenza vaccines for adults and children with chronic medical conditions. As you can see, influenza vaccines are available across the board for these categories or these medical conditions, I should say. Next slide, please. So which vaccines are currently available in each jurisdiction? I have tried to map this out as best as I can, but small caveat, some of the information is not currently available in 3 jurisdictions. I usually have this information verified by the Canadian Nurses Coalition for Immunization before I post this. So this will be duly updated following this presentation to obtain the additional information that's missing and to verify the one that is. As you can see, most of the jurisdictions are offering a quadrivalent vaccines. I believe it is in this list, Ontario is one of the provinces offering the mammalian cell vaccine, or the cell cultured vaccine, I should say. Some of the jurisdictions are offering the high dose outside of the extended program, and by extended program I mean that all residents of long-term care facilities will be receiving the trivalent inactivated influenza vaccine in this high dose, I should say, this season, and that's going to be happening in long-term care facilities. So there are some jurisdictions that are offering it as part of their standard flu or seasonal influenza program. Next slide, please. So if anyone has any questions, I hope I've provided enough guidance to start this conversation on the right foot. There is a lot of information with regards to policies and programs, and I've only touched the tip of the iceberg with regards to that, to this subject. I can safely say that this is a topic that can probably be a town hall on its own. So to do it in 13 minutes is quite a challenge. Thank you very much for your attention.
And thank you very much, Lucy. I think what we can say is certainly, you know, you're an expert in the field in terms of knowing the nature of the vaccines from an advocacy perspective. You know, one of the things that worries me terribly though is this is very, very complicated, isn't it? Isn't it? I mean, it just says to me that it's, so I have a 92-year-old mother and she goes to the doctor. Is she going to get a standard or a high dose? You know, does she know what she's getting? I mean, I think there are a number of different questions that need to be asked. I think also, you know, NACI makes its recommendations, but it's at the provincial level that they decide, you know, what's funded. You know, and I think that's another layer of decision making that would be, you know, interesting to unpack. What are your thoughts about that, Lucy? My comments before we go to Jeff.
Well, that's one of the reasons why NACI extended its mandate to look at economic issues with regards to vaccine programmatic implementation, adopting new programs. But ultimately, as you said, it is up to the provinces to allocate funding, costing, and it's also based on population needs that they base that kind of programmatic expansions. So that's mainly the reason why NACI expanded, but unfortunately it's very complicated web of relationships. The benefit, however, is that they do all work together, and that's important. If they were working in separate silos, that would have been an even bigger challenge. But the fact that they work together, there's coordination. So for example, vaccine procurement, there's coordination on many levels, including evidence sharing and discussions and meetings. So it's a well coordinated approach, definitely.
Yeah. So that's something to be positive about, the collaboration and partnerships and sharing of information. So that's certainly on a positive note. That we go to Jeff Maltretter. Now, Jeff, IFA is an advocate of pharmacies being an important gateway for older people and people of all ages to be vaccinated. So we're thrilled that you're here today to talk with us a little bit about the work of pharmacists and particularly, you know, the Neighbourhood Pharmacy Association. So welcome, Jeff.
Well, thank you, Jane. Thanks, Andrew, for bringing up the slides. Maybe what I'll do just quickly is give a bit of an introduction into who Neighborhood Pharmacy Association of Canada is. So we are an organization, basically a trade organization. We represent pharmacies and the pharmacy retail organizations across Canada. Our members will be, the names you'll be familiar with: Shoppers Drug Mart, Rexall, Pharmasave. We also include amongst our membership organizations that have a pharmacy in their store. So for example, the grocery stores, Walmart, Costco, those sorts of pharmacy operators as well. And our members are, it's important to note this, I think, based on the comments, Jane, that you've made and that Lucy has made. Our members straddle provincial boundaries. So we have some that are, national in scope. They have pharmacies in, every province. And we have some members who are, quite regional, but they may only operate in the West, for example. But they're quite familiar and have to grapple with the differences from one province to another. And this sometimes does create challenges for pharmacy organizations as they organize their vaccination campaign. So that's just by way of a bit of an introduction in terms of who Neighborhood Pharmacy Association is. If you could go to the first slide, please. So I'll speak a little bit about pharmacy and who's getting immunized in pharmacy, why they're there, and then some of the challenges and the opportunities from the perspective of pharmacy as we look into the future. If you could go to the next one, please. So this has become a common sight in Canada. I think, unless you've been very sheltered, you have become familiar with these kinds of promotions and signs and encouragement to get your flu shot in the pharmacy. And certainly when most Canadians think about immunization in the pharmacy, they're thinking about influenza. And it's reached the point where most Canadians, or a large number of Canadians, are getting their flu shot in the pharmacy, and they think of the pharmacy first when they do that. So pharmacy has become pretty good at this type of immunization. I wouldn't say that we're experts or that we're well suited for all types of immunization, but for influenza, I think we've demonstrated that we can do something quite good and that Canadians appreciate it. So, if we go to the next slide, please. So this is just to give you an idea of how much this has grown over the past decade. Really, if you go back just over 10 years ago, there were no immunizations, no flu shots in pharmacy at all. And over the course of a decade, the number of immunizations in pharmacy has grown. It's well over 3 million now, and that puts it in the range of about a third of the influenza vaccines that are delivered in Canada. So it's a significant and important channel for Canadians to get their flu shots. What we've also seen is that this growth, when you look at this in different provinces, there's a very consistent pattern of growth for each province as they come on board and they have authorized pharmacists to deliver vaccines. The pattern has repeated itself across Canada, that the number of flu shots delivered in pharmacy just continues to rise year over year. And BC and Alberta were the first provinces to allow pharmacists to immunize, and they have today, the highest share of flu shots are delivered in pharmacy in those two provinces. If we could go to the next one, please. So I'll just direct your attention to the little photo on the side here. So this is information, a sign. It was actually from a sign that London Drugs put together promoting their flu shot campaign. But these numbers are consistent in many cases from surveys from other pharmacy retailers. When you ask the general public, where did you get your flu shot? It's getting close to half of the general public are saying they get their flu shot in pharmacy. So this number is citing 52%. I've seen other surveys that are at 48%. And that's because those surveys are reaching the population that is at large. When you start to count the population in long-term care centers or in hospitals, et cetera, it starts to look more like a third of all flu shots. And we're going to talk a little bit about what are some characteristics of the people that are coming to pharmacy and who have decided that they will go to pharmacy. I will make one note. I talked about different provinces. This is the first year that Quebec will start to immunize or allow pharmacists to immunize. So they've picked a particularly challenging year to start because of the COVID-19 situation. But Quebec is the last province, and now all provinces allow pharmacists to provide an influenza vaccine. So we'll just go to the next slide, and we'll see some more statistics here. So these statistics are taken from a survey that we did about 5 years ago on patients who had just had their flu shot in a pharmacy. And some of the key information, 90% of the people who got their flu shot in that season about 5 years ago, they walked in without an appointment. They just walked in. Most of them waited less than 10 minutes before the pharmacist was able to deliver their shot. That 10 minutes does not include the post-shot waiting time. But the end result was overwhelming satisfaction with the speed and the convenience of being able to go and get their flu shot in the pharmacy. And this has replicated itself year over year. When we did this survey, we also asked people about what their intentions were for previous years, and it became pretty clear that once they had decided to get a flu shot in the pharmacy, there were very few people that switched back to getting their flu shot from another channel. So most people have, or many Canadians have voted with their feet and tend to go back to the same pharmacy again and again because it's a convenient and quick way for them to get their flu shot. We could go to the next one, please. So this chart is something that I think we came out of the survey work that we did a few years ago, and it really hasn't changed all that much. What we found is that the largest groups or demographics of patients coming in to get their flu shot were really the working Canadians. 24% of those who had their flu shot in the pharmacy are in that 55 to 64 sort of near senior category, and the next highest segment is the 45 to 54-year-olds. So those are Canadians that are in their prime working years. They're busy, they're time constrained, they have family obligations, and that's why pharmacy has proven to be a convenient way for them. When you look at the other end of the scale in terms of those over 65, you can see that it's still a pretty significant portion, you know, almost 23% for those over 65. But that, you know, was a little bit underrepresented when we looked at the total age groups of Canadians available. And we surmised that perhaps what's going on there is that many seniors are already visiting their doctor, and it's convenient for them to receive their shot when they visit their physician for another reason. And physicians are very good at making sure that their patients who are over 65 get their flu shot, especially if they're coming to see them on a regular basis for another condition or some other reason. We could go to the next one, please. So, looking ahead, you know, we're going from a situation where, you know, you have this happy gentleman on the left here getting his flu shot, and you know, to a situation where both the patient's wearing a mask, where the pharmacist is wearing protection, and you know, the situation is very different. So there's going to have to be changes. And the picture on the right is actually taken from a newspaper article from the Vancouver Sun, I think it was. And the title of that article was, you know, flu shots are going to change this season, because patients will no longer be able to walk in quite as easily and get their flu shot quite as quickly as they may have in the past, because of the fact that we are in this twindemic, some people are calling it, situation. So, you know, the idea that we have COVID-19 and influenza, and all the other respiratory infections that plague us in the wintertime, all coming at the same time. And, you know, there will be issues around, number one, patients distinguishing between what, you know, the symptoms that they have. Do they have the flu or do they have COVID? Or do they just have a cold? So there's going to be some challenges. Patients won't get it right all the time. Pharmacies are not keen to have patients with COVID symptoms into the pharmacy. As a matter of fact, their direction throughout the pandemic has been, if you have COVID symptoms, please go to an assessment center. Don't come to the pharmacy. And that's the exact, you know, or that creates a potential issue where patients may get it wrong, right? I think we can count on that. The second issue that we're going to see is, you know, the rising case counts, the second wave. We're already seeing this significantly in Ontario and Quebec. And, you know, will this lead to a more of a lockdown and a fear to actually come out and get your flu shot? You know, the immunization is not something that can be delivered virtually. So, you know, we need to actually get people to come, or somehow get the immunization to them in a way that is safe for everybody. And that safety is certainly something that pharmacies have been working on over the past, gosh, since the summer started. You know, ourselves and the Canadian Pharmacists Association, we recognized back in May that, you know, we needed to start thinking about this for the fall, because there were going to be issues. So the Canadian Pharmacists Association, they did some great work to develop guidance for pharmacists and for pharmacies in terms of how to immunize safely in a pharmacy setting. One of the things that we're expecting to see, which will be a change for patients, and we will have to manage their expectations, is, moving to an appointment-based model. So, patients are used to walking in, as you saw earlier. Pharmacies are now trying to encourage patients to make an appointment to come in, and they're trying to do that so that they can pre-screen the patients for COVID symptoms, and make sure that any patients who could have COVID are not coming in to get a flu shot, or not just dropping by. So, that's one of the main reasons that they're doing that. Plus, it also means that they can plan better. They can have, the right amount of PPE on hand. And they also, because there may be, because there's more issues in sanitizing and cleaning between patients, they want to space the patients out, and they don't want lineups of patients waiting to get their flu shot. So for all of those reasons, we're starting to see, or will see, appointment-based flu shots more in pharmacy this season in particular. And there's there's at least 2 software programs that have been developed to help pharmacies manage that sort of situation, to schedule those appointments and do the screening ahead of time. And there are some fringe benefits to that. We can talk a little bit more about that, because the next item down is the demand planning. And one of the benefits of some of these new softwares is that they allow the pharmacy to manage their inventory, so that when they receive doses from public health, or from the pharmaceutical distributor that they deal with, they can then contact the next people on the waiting list and say, we have a dose for you that's ready to go. And so in this way, they're hoping to manage inventory better, plan their demand better, because they'll know in advance how many doses they'll need. And really, it should end up with a much better experience for patients, because patients won't be coming in and then be turned away because they didn't have a dose for them. So there may be some good things that come out of the COVID situation. If we go to the next slide. So other challenges. I don't want to suggest that the only thing that pharmacists do is influenza. In some provinces, they're more restricted than others, and they only do flu. But in other provinces, they're able to do a wide variety of immunizations. And but I will say that moving beyond flu has been slow in those jurisdictions where they can do that. So by far and away, most of the immunizations are flu. The message has gotten across to patients that they can come to their pharmacy for a flu shot. It's been much more difficult to get them to come to the pharmacy for Tdap, or for shingles vaccine, or for a pneumococcal vaccine. This is just not, even if that is funded or authorized in that particular province. There has been a study that's been done in New Brunswick and Nova Scotia. It's run by Dr. Jennifer Eisner out of Dalhousie, and this study has specifically looked at how pharmacy can increase the coverage of adults for those sorts of adult vaccinations. And they've published one paper in the Canadian Pharmaceutical Journal, and I believe there are some more papers that are coming. Their study's been a little bit disrupted because of the pandemic, but I think much of the work has already been done and will be published in the near future. And the early results suggest that the pharmacies, when equipped properly with the right education materials, have been able to make a significant difference in bringing vaccinations to the adult population. One of the challenges that we face in Canada, and you know, I think Lucy may be able to comment on this as well in this, you know, when we get to the discussion part, but there are information silos that exist because we have provincially oriented healthcare, and that I think are not serving patients well. So in particular, we think it would really be great if we can enable patients, regardless of where they get their immunization, that information is easily accessible to them and shared between all healthcare providers. And today that is much more difficult. It's not easy for the pharmacist and the family doctor, for example, to share information on which vaccines the patient has received. And you know, I think we just need to break down some of those information silos that exist. And the thing is that patients, when you talk to them, they look at the interconnected world that we have today, everything on their mobile phone, and frankly, they can't understand why this is not happening automatically. You know, I very often hear from patients or from, you know, my friends and family when I talk to them about this and say that, well, look, the information is not shared with other healthcare providers. And they look at me incredulously and say, well, how can that not be happening? Isn't that just automatic? And I think that's a challenge, but I think it's also a fantastic opportunity to really help patients know what they're missing and what they need to get, and reassure them that they've been immunized for everything that they really should be immunized for. There are also some issues related to funding. So in some cases, you know, when we look beyond influenza, the vaccines are not available to the pharmacies. In some cases, payers require the patient to go to a physician to get a prescription before they'll pay for the vaccine. The pharmacies, so what you end up with is you end up with a patient who, you know, can purchase the vaccine at the pharmacy and then get reimbursed through their health plan, but then they have to go back to their doctor and get a prescription for it. So it becomes a bit of a laborious journey for the patient, and it's not always clear up front, you know, what they're going to need to do. So I think there's an opportunity to streamline some of those funding issues and streamline what's available to pharmacies in a way that just makes it easier for patients. If we think about the opportunities, you know, because we shouldn't dwell on the challenges too much, because I think hidden within each challenge is an opportunity. You know, we really want to and have been emphasizing that when it comes to mass distribution of a COVID-19 vaccine, pharmacy is very well placed. We've done this kind of work before. Pharmacists are good at delivering vaccines, and especially in large programs where we're trying to get out large numbers of vaccines in a short period of time. And we think, you know, relying upon pharmacy to help manage and distribute those vaccines and immunize Canadians is a really good opportunity. And most of the time when we've talked to you know, provincial governments and provincial public health, they agree as well. Why wouldn't we use pharmacy? And you know, it's just a matter of making sure the right guidelines are in place. I'll point out, how am I doing for time there, Andrea? Am I oh, still okay? Okay, good. one of the other things that we have advocated for is to use the pharmaceutical supply chain for distribution of vaccines. Pharmacies receive all of their drugs, almost all of their drugs, from a pharmaceutical wholesaler. These companies have become very sophisticated, very secure as well. Canada has almost no issues when it comes to counterfeit drugs, partly because the supply chain is so well controlled in Canada, and it's very efficient. Most pharmacies get same-day delivery for their drugs. Some pharmacies will get deliveries twice a day. And what this means is that they need to carry less inventory. And this becomes very important from a public health perspective, especially in a scenario where you may have less than adequate supplies for everybody. So, wastage isn't important. And that way you can have less inventory sitting on the shelf and more inventory in waiting to go out quickly. I think I mentioned data. There's an opportunity here for a really comprehensive patient immunization record that's easily accessible. We haven't really had good guidance on that. And I think the scheduling software that we started to talk about earlier is a real opportunity. I think it will help with the demand planning for the whole system, because pharmacy can feed this information back to public health authorities and use that, very detailed information to help plan the next influenza campaign. So I think that's the last slide. Am I right, Andrew? There's one more. Oh, okay, and it's time to lead into to questions.
Thank you very much, Jeff, and also thank you to Lucy. The objectives of the session today was to try and understand some of the complexities of the National Immunisation Plan, across provinces. And I think Lucy, very eloquently and as simply as she could, laid that out to us. I think the other aspect was to understand some historical context, and Lucy also positioned that. The other part of the conversation was really what Jeff did was, to present very clearly, one of the vaccinated gateways in terms of pharmacy. But in doing so, he highlighted some very, very particular areas that could do with some work, collective work. IFA likes to think about across disciplines and across sectors. And some of the areas that you mentioned, Jeff, education. And I think it's not only education for healthcare professionals, but it's also understanding what message to the consumer stimulates them into action. I think, you talked about data, and Lucy and others on the line today would be much more able to answer the question about whether we have accurate national registers, or whether they're provincially based and they don't talk to one another as in Italy. And that's not the case, but do we have accurate numbers, and is it disaggregated by age, for example? Rather than 65 and over, is there a disaggregation? Some of the other aspects, Jeff, you talked about streamlining, the process and also the funding, and what are the guidelines? And I think it's not only, these guidelines, as Lucy said, have changed this year, and how do we ensure that healthcare professionals are really up to date with the guidelines? At the heart of this conversation, I still want to put out, to the group here today, do we need a harmonised program? And perhaps if we are all starting with a blank sheet of paper, the answer may be yes. But some of the solutions and issues that Jeff presented, and also in the context of what Lucy said, may help us to answer that question in a slightly different way. So I'm going to open it up to the floor, and I know that people have been answering questions in the chat box, Andra, please come forward and ask your question.
Thank you very much for the presentations and for the opportunity, Jane. We see that different stakeholders do have different roles to play. And is there more that can be done by these different stakeholders to advocate for a national vaccination schedule? And for example, Jeff, would pharmacies and pharmacists benefit from a harmonized course schedule? Thank you.
Yes, I think pharmacists would benefit from a harmonized schedule in terms of the vaccines that are available. But I really think they would in particular benefit from harmonization on, for example, patient eligibility. So every province has different rules for who pharmacists can vaccinate, and in some provinces it's over 2 years of age, in some provinces it's over 5 years of age. It's different everywhere. So I think, frankly, in many cases, pharmacists, they don't have concerns about which vaccines are chosen, but it's the immunization guidelines that really could be better harmonized, I think, and that would help. There's another, I had another thought here and it's escaped me, but the way that, I did want to also mention in the way that vaccines are distributed as well, because in some cases, each province does their own thing in terms of distribution. And, we think that the most effective and the most efficient way is to use the pharmaceutical distribution system. It really works very well. And it's something that maybe public health needed to have control of that at some point. But, let's let public health focus on tracking and tracing and doing all of the things they need to do these days, and not get too caught up with distributing influenza vaccine. We don't think distribution is something that is a huge, it's not something that public health should be really focusing their attention on.
So Lucy, I just wanted to go to you and ask you about the comment that Jeff made about patient eligibility. And it is very confusing, and you're sometimes at the table where these big conversations happen. So has there ever been any discussion about harmonizing even the schedules, across the country?
Yes, and so I wanted to address actually the first part of Andra's question as well, but I'll do both at the same time. When I first started, just a little over 10 years ago, one of the first things that I did was to write a letter to a Senate committee about harmonizing immunization schedules. In fact, it was one of the main priorities for a lot of stakeholders for many, many years. I think there are legislative barriers to be able to have a harmonized immunization schedule, and that goes not just for influenza, it goes for routine immunizations such as childhood immunizations and adult immunizations. So I think it's a lot more complex than it seems. There's a lot beneath all of the layers that you have to peel away when you're looking at trying to harmonize the schedules. So yes, and again, it has to do also with the fact that we are a very large country, spread out, and population needs. There's a lot of different population needs. So that is one of the biggest challenges in Canada.
I think next week or the next time we meet, we're going to hear from, the United Kingdom and Australia, where they do have harmonized programs, with comparable populations. So I think it will be interesting And we'll come up against this problem again about, well, it's the jurisdictional responsibility. And yet, you know, and it is complicated, and I understand it, but it feels to me as though, you know, the bottom line, it's the economics. There's something in me that says, well, it's the economics. And that's why certain provinces, you know, seem to shift their schedules. And I was talking with friend and colleague Danny Prudhomme yesterday, CEO of FEDOC, and we were talking, Danny, about what's happening in Quebec. And I think that's an important conversation. Would you like to just comment on that?
Yep, thanks, Jane. Basically, as we were talking yesterday, is if you go on the government website, where someone was asking, especially in Quebec, if seniors were covered, if you go on the website, it's actually the website from last year that they did not change. So because probably they didn't have the time to change because of the pandemic. But the beginning of the year, they actually said that they would not cover 65 to 74 anymore. Now, what's on their website right now is what was there last year. So I guess because of pandemic, they're going to cover again this fall. But unfortunately, and when we were talking about jurisdiction and doing their own thing, Quebec is going with analysis of the population in Quebec instead of taking analysis worldwide, where it says that 65 and over should be free for everyone. So that's one point. And the second point is we're aging more rapidly in Quebec than other provinces. For example, 65 plus, we're over 20% or so, whatever, population, going towards the 22%. And costs-wise, they just cut down on vaccination 65-74. They went from what we call the original medication to generic. So many ways trying to save money. And yes, that's a bad thing.
And thank you for that. I think the first thing that worries me is that websites are not up to date. I think that's the first thing. And also sometimes the information is so buried in websites that it's very difficult to actually understand what you're eligible for. The return on investment, you know, for vaccination should not be underestimated. So thank you for your comment, Danny. Lucy, did you want to say something?
Yes, and very much like Danny's comments, when I was putting up my table together in the last slide on my deck, and I just realized I have a mistake on it. Someone was commenting. The information is not easy, and I do this every day. It was not easy for me to find, and normally, like I said, I go through back channels to get that information quite quickly. Unfortunately, those back channels weren't available to me in time for this presentation. But if I can't find it, how can someone who doesn't do this every day find it? So that is a struggle. And even just a simple list of what vaccines are available in the province by age group, or, you know, most of the provinces do have it up to date, but some don't. So
I think also what we need to appreciate is it's older people and those with underlying chronic conditions, you know, who are most at risk. You know, those with heart conditions, diabetes, lung conditions, you know, the non-communicable diseases that many older people who have at least one of those chronic conditions. And so, you know, we need to sort of be thinking a little bit more broadly. IFA is in the midst of a study where we're actually talking, you know, to some of these representatives of member organisations for diabetes and heart. And it's not that these organisations do not want to promote vaccination. That's not the issue. But their core business is hearts. It's not vaccination. And so if messages and information are not clear, or they're difficult to get to, and it's not their core business, then it's going to be hard to bring them on board to say, you need to be part of, you know, team vaccination this year. So I think we need to be really thinking about how we reach across to patient groups, as well as those who their core business is immunisation. And equally, Jeff, you know, partnering with pharmacists and, you know, Canadian Medical Association, etc., to have, a cross-cutting approach could be something valuable to think about. What do you think?
Well, going back to what you said earlier, the first thing you said, I think unfortunately many of the program decisions are influenced by budgets, and they're influenced by money, and provinces are at different stages and have different pressures on their healthcare systems. So not surprisingly, some of these decisions mean that, or some of these things mean that the provinces make different decisions because they feel like they can't afford it. In terms of harmonizing the program, I think the programs. I think one thing that I'd really like to see is greater clarity on or guidance from the provinces in particular on who's, what are the guidances for this. So for example, let's go back a couple of years, and in Ontario, when high-dose flu or high-dose vaccine first became available in Ontario, there was not enough vaccine to go around. But there was not a lot of guidance to say, these are the patients, these are the Ontarians that we need to make sure get that. And then coordinating that and providing the same information to pharmacy, to physicians, to all the potential immunizers, so that together they can ensure the best value is delivered, right? We have to recognize that we may not be always able to have all of the vaccines that we would like, but at least let's make sure that whatever we have is delivered in the most efficient way and clinically effective way, so that the right shot gets in the right arm. I really believe we could do a better job of setting up those guidelines.
Who sets up the guidelines, Jeff? Who does the education? Who does the, I think they're important questions. Who does that?
I think, in my experience, that those sorts of guidelines come from the provincial public health.
Do they need some help?
I think they just, I'm not sure what the reason is why they've not been able to clearly say, the population of our province over 65 is this, and that means that, we can only deliver a limited number of vaccines to that population, or we don't have enough for everybody. So, this is how we're going to divide it up. I don't know why they don't seem to want to make those decisions.
We're gathering all of these, chat pieces because they're going to inform our conversation going forward. But as we move into an unprecedented situation of a potential COVID vaccine, I think, as I said to my colleagues at WHO the other day, let's pretend that we have a vaccine that is 100% effective for older people. Let's just pretend. And we've got the vaccine, but we actually can't understand why older people are not rushing to be vaccinated. And sometimes I think the same conversation should be had around, influenza, pneumococcal pneumonia, shingles, standard dose, high dose. So, what do we do then in terms of, we have this COVID vaccine, and it's certain provinces have made it eligible. I would guess, Lucy, in COVID, it would be a national statement. I would hope so. But let's say that it's everybody over 70. How do we ensure that we can mobilise those 70 and over to be vaccinated? Because that's what we should be doing for influenza. So,
if I may, Jane,
yes.
attempt to answer your question. The first thing, and this step is actually already taking place, is to educate the healthcare professionals. So immunize it.
Yeah, can I just come back and be the devil's advocate and say healthcare workers are not great at getting their influenza vaccination, and I've already heard hospitals say they fear the healthcare workers will not be vaccinated against COVID. So, you know, we actually have to be realistic with what's happening out there. But I agree with you.
But that's why it's so important that we do educate them and, you know, explain to them the safety data that we do have and what we don't have, and take them through the process of vaccine development, explain to them the different types of vaccines, because with COVID vaccines, there are different types, many different types, and there are several.
As with influenza. You know,
Yep.
So I guess my argument is that we've got COVID vaccine coming down the train tracks at us, but we're still not doing a very good job with those that are tried, tested, and true. So what do we do?
Well,
Well,
I think the question
sorry,
with a potential COVID vaccine is a little bit different. And I think we have to recognize that probably what's going to happen is that we'll have waves of vaccine released because they probably won't be able to manufacture it all at once. And so the question will be, we have 3 million doses. Who are the first 3 million Canadians that should get it? And you know, I'm presuming, Lucy, that that's the kind of work that's being done today, and it'll be based on where the greatest need is. You know, so healthcare workers might be right at the top of the list, but you know, there does need to be very clear guidance given to immunizers, pharmacists, and physicians in the community, in healthcare settings, to say, here's the triage, here's who gets it first, here's who gets it second. You know, let's make sure that out of these X number of doses we have, we get the most value. And then when the next wave of doses is released, there's a new list, a new triage list that helps.
Yeah. Now, Lucy, I cut you off. So finish what you were saying, because it's important.
No, I was just going to continue what Jeff was saying. But in fact, with COVID, what we don't know is what are the benefits with regards to different types of populations. So if we're talking about adult immunization, and you're talking about older adults who have immunities that immune systems that don't work as well as younger adults and children, we don't know how that's what the outcomes will be for them. And so we're still at such an early stage trying to figure out and identify who should get it first and who should be first in line. Also, vaccine supply is that other issue. So there's a lot of complications, or there's a lot of factors that need to be taken into consideration before proper guidelines can be delivered.
Sure.
At the national level.
Look, you're absolutely right, and I was being slightly provocative. However, it's important to be. We do know that the clinical trials, some of the clinical trials have cohorts that are 80 years of age, and that's a very positive thing, and it's a very unusual thing. I'm going to ask Diana Cable. Diana, would you like to answer ask your question?
I thought it was very striking, and I've known this for many years, that healthcare workers often don't get vaccinated. Is it because they don't believe that the vaccination is effective, or is it because they are afraid of possible side effects? Do we know?
Yeah, yes, we do know. We certainly know something, so I won't start that off. But Lucy or Jeff, do you know very much about this area?
I don't really know much about this. I don't know if Lucy.
Okay. Look, Diana, great question. So some of the evidence that we have is that they certainly that I won't get the flu. I'm healthy. So it's some of that goes
Really?
on. Yeah, it's some, you know, not all, but that certainly has been, you know, some of the responses when we ask. And I'll give you a very good example. IFA was in an international meeting in Japan, and there was a senior nurse specialist who had turned 65, and she was sent a letter by the government to say, you are eligible for your free pneumococcal pneumonia vaccine. And she was asked whether she was going to have it, and she said, no, I don't need it. I'm really healthy. And that was a senior nurse specialist. So sometimes we actually take our hat off. Certainly there is vaccine hesitancy for some healthcare professionals, because they're people too. So I think there's varying reasons, but that certainly has been written up in the literature. So I'm just going to begin to close now, and with gratitude thank Lucy. You're an expert, Lucy, and it's a delight to listen to you. I learn something every single time, and certainly you've worked out which vaccines are in what provinces for whom. So congratulations on that one. Thank you once again. And Jeff, absolute pleasure to learn more about the neighbourhood pharmacy group. I think what really captured my interest was your ability to move between professions and personal and give anecdotes, and then also come forward and say, these are some of the things that I would like to see happen. And I think that's really important. You know, these are some of the things I've been thinking about it, and these are some of the things. So we're capturing those because we think, as IFA working in partnership, these are some of the things that we should be raising the noise level up, having the dialogue, and seeing, you know, which areas can we slightly prod and push. So thank you very much for your inspiring presentation. Wow. Thank you for all being here today. And Danny, yes, can we get the presentations? Absolutely, with the permission of Lucy and Jeff, who were both nodded. And going forward, our next webinar, we will certainly have presentations that we'll be able to package up and send out. I am now going to hand over to my colleague, Andra Stanku, who is going to provide some closing messages, Andra. And before I do that, because you will close off, thank you very much for being part of this. Stay safe, stay well, and be with us in our #2 webinar, where we'll bring some international practices. Once again, thanks to Securus, Kim and her team for enabling this important series to happen with an unrestricted educational grant. So Andra, please take us home with some closing messages.
Yes, thank you very much, Jane. And once again, thank you, Lucy and Jeff, for the very thorough and thoughtful presentations. And just further to something that Jane touched upon, these are just some of the takeaway messages that really hit home and that we can take forward to the next meeting and to future discussions and meetings. So first of all, of course, the importance of collaboration between monitoring and advisory bodies and the FPT decision makers to provide that clear and accessible information and guidance, not only to Canadians, but also to healthcare workers. Number 2, Canadians are seeking convenience. Pharmacy vaccination undoubtedly increases access and makes it convenient for Canadians to access the appropriate vaccinations for their needs. The pathway does need to be simple, clear, and straightforward. Number 3, there's more structure coming, both in terms of administration, so scheduling and logistics delivery, to expand pharmacy vaccination. Number 4, the importance of enabling patients to have the necessary tools to manage their immunization. And number 5, harmonization is needed not only in terms of which vaccines are covered and recommended, but also in terms of the eligibility to be vaccinated by different vaccinators. So in pharmacy, for example, and as well in the distribution systems of pharmacies across the country. So those were just some of my takeaway messages that we can take home for the IFA from our perspective. And we do welcome your participation and to take these conversations forward to the next upcoming meeting. I'll just share screen again here for more information. An invitation will be sent by email. And so on October 14th, we will be discussing strengthening adult influenza vaccination programs, learning from international good practices.
And thanks very much, Andra. And tomorrow is the 1st of October. So we celebrate 75th anniversary of the United Nations and the 30th anniversary of the International Day of Older Persons. So celebrate with someone, stay safe and stay well. And thank you very much for being with us today. Thanks, Lucy, Jeff, Andra, Megan. Bye.